Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. Welcome to MIOM webinar meeting with an eminent speaker from different parts of the world. As usual, MIOM Academy deliver a very high level of scientific meetings. In this year, we are also very glad that we are delivering a new way of competition between a young ophthalmologist. They are well expert, some of them, but we say young because they are below 40 years. Others like me below 20, so that we are not. I'm not included. Me and George below 20. Hassan is above 30, so he is a little bit older.
I accepted to be the adult here, no problem.
I'm very happy that we are here today, and today we are having really a very informative and discussion will be going on, inshallah, and it will be about retina. Maybe it will be the last meeting for the retina. From in Ramadan we are going to stop, then we will start again in April with other meeting. Today our meeting is sponsored by Bayer, and thanks for them for sponsoring this meeting. And the first, we are going to divide this meeting in three parts. The first part, it will be like a symposium for the buyer. Then we will have the young ophthalmologists. They will give their talks, and it will be evaluated by the expert. And today, at the end of the sessions, we would like to announce the last meeting and today meeting, the winners. And by the way, all of the people they are getting here, they are winners. If they are not the first, but they are going to be winner, I will announce what they are going in the end of this meeting. And then at the end of that, they will have a final and most what we call heavy bulk of the delivering message and delivering information by our expert. We have Dr. Jacob, Dr. Nabil Rifqa, George Rukka, and Dr. Hassan. Also, the young ophthalmologist, we have Dr. Polka Isilk, yes? So I don't know if my pronunciation is good or not, please. Muhammad Saad, she's from Turkey, and Muhammad Saad from Pakistan, and Sidrat Manju, from India. So it will be a great, and we hope that we will enjoy today the meeting. So without any further ado, we would like to first to have Dr. Hassan Hasid, and he will give the talk, symposium about 8 milligram Eylea update.
Assalamu alaikum. Just let me. I want to thank Dr. Muhammad first for the chance to present today, and I want to thank Bayer for the sponsoring and support. And today I hope that I can present some of the already data you know it, and maybe something new already came from Eylea 8 milligram. As you know that just for to that the disease incidence has decreased, especially these exudative retinal diseases like AMD and diabetes, which expected in the coming decades that maybe 100% increment in our area. And again, diabetic macular edema is still these patients with these comorbidities, the treatment burdens affect these patient treatment plan. So for that, there is unmet needs to be solved. And for that, maybe most of the medication which are available now try to help us by this. If you go that this treatment, still there is high treatment burden, poor long term from the patient, non-adherence, cost, and suboptimal maybe control for the disease, and increased number of the patients and from these diseases. And again, if there is any survey, still there is reducing the treatment burdens. And we hope that Eylea 8 milligrams with this fourfold higher molar dose than the 2 milligrams will, by increment the suppression of the VEGF, will give us our option to better control for these diseases. So if you go just for to review about the pulsars, which were done for the AMD, the study, the randomized control studies, double blinds, which compare between 2 milligrams aflibercept and 8 milligrams. You can see there's 3 arms, 2 milligrams fixed after the loading dose. The fixed dose was every 8 weeks, and aflibercept 8 milligrams it was two arms. One will be intervals every 12 weeks, and the other arms will be 16 weeks. There's 1 year, and the primary endpoint in the first year around week 48 to see if there is any change in the best corrected visual acuity. And there is another secondary endpoint which was important for that, to see the dryness effect for 8 milligrams comparing by the 2 milligrams and the 16 weeks after the loading dose. And the study will be ended in the second year in the week 96. And there is the option to enter the extension, which will be open label for and I think the result will be coming soon. So we go further in the study to aware about how to manage the doses. That after the three loading doses, that in the first year there is no extension, but there's shortening if it was happen for the patient. That the shortening criteria will be if there is any decrease in the loss of the number of letters more than 5 letters, and with increment in the central retinal thickness more than 25 microns, then the will be some shortening in the extension, the intervals in the arm of the 8 milligrams, and the shortening should be by 4 weeks, and it shouldn't be the interval less than 8 weeks. On the other side, the extension in the second year, it will be offered for the patient in the 8 milligrams arms. The extension it will be 4 weeks, and if the patient has a stability, I want to mention about something, that all of these result about the extension and comparing the dose regimen modification, always compare with the primary result in the 12 weeks, which will be very important after the loading dose. So the extension in the second year will be depending on the result from the 12 weeks. So the extension can be if the patient there is no decrease in number of letters more than 5 letters, and the stability in the OCT, the patient can be extended by 4 weeks increments, and shouldn't be beyond the Q20 or 24. Criteria inclusion and exclusion, I will not go on the depth. Demographic exclusion, you can suggest was accepted for the study. And about the efficacy of 8 milligrams and the vision gain, if you go for the chart here, you can find that the mean change in best corrected visual acuity in the end of the first year, 48 weeks, was comparable between the three arms. There is no inferiority between the 8 milligrams to Q16 to Q12 comparing by 2 milligrams on the fixed dose. Again, as I said for you before, the secondary endpoint, which was looking for the dryness, the intraretinal fluid, subretinal fluid, and after the loading dose, week 16, you can find that the proportion of patients in the arm on the two arms of 8 milligrams was more drier than the patients in the 2 milligrams. And about the extension, which is very important for us. And you can find that by the end of the first year, that's around 83% of the patients, and they maintained the Q12, and by end of the 49 weeks, and 77 of the patients maintained the Q16 intervals too. And by reaching the week 16 in the pulsar, we found that mostly around 43% of patients who was on the Q12 reaching the Q16, and around 39 patients on the Q16 reaching the Q20. So now in our hand, 8 milligrams is the only approved anti-VEGF for Q20 intervals for treatment of AMD. So yes, we have good comparable results by visual acuity and extension and reduction of number of the injection for the patients. Again, to go for the photon, we look after the diabetic macular edema treatment, comparing between 2 milligram aflibercept and 8 milligrams again in the Q12 and Q16. After 5 loading dose, 2 milligrams, then it will be fixed dose every 8 weeks. The aflibercept, as we said, 3 loading dose, and after that, it will be the intervals for Q12 or Q16. The primary endpoint in week 48, first year, I find it easily for me. Primary endpoint was changing in the visual acuity, and the second year it's already published. Even it was on in the weeks 96. Then here was, because I will even some go for the extension results, which will be the photon extension. After that, it's open label, give the choice for the patient to enter this extension for 1 year. So if you go in detail in the chart for the to understand the extension and the shortening, in the first year there is no extension, just shortening if there is no if there was worsening in the results. When the dose regimen modification will be in the first year, even the second year, it will be as usual. The shortening will be 4 weeks, and if the patient lose vision, the number of letters more than 10 letters, and with increase in the central retinal thickness more than 50 microns, then the patient will be shortening by 4 weeks, and the shortening shouldn't be the shortening and extension will be just in the arm of the 8 milligrams. So the shortening will be no more than 8 weeks, and if we go for the second year, if we go for the second year, the extension criteria is again stability of the number of letters, no lose more than 5 letters, and the stability in the OCT, and the increment will be by 4 weeks. It will not be go beyond 24 weeks. Criteria exclusion, I will not go by. Demographic distribution was acceptable, and the most important thing will be for us that around 44 of the patients was previously treated as in our hand in the real life. If we go for to check the efficacy of the field of perception and the visual acuity, you can go for here to see the chart of the mean change and the best visual acuity was around comparable between these three arms. There is no inferiority comparing between 8 milligrams to extension criteria with 2 milligrams. Again, for the extension treatment intervals, if we go in detail, we can find that around 93% of the patients who in the 8 milligrams maintained the Q12 intervals by end of the first year, and more than around 89% of the patient maintained the Q16 intervals by the first year, by the end of the first year. So by reaching the week 60, the most around 43% of patients on the Q12 reaching the Q16 extension and intervals, and around 34% of patients on the Q16 reaching the interval Q20. And again, it's the single approved by FDA for anti-VEGF by intervals for Q20. About the extension, as we said, the idea of the extension is that the patient who already in the 8 milligrams Q20, Q12, and Q16 will be continuing the same on the assignment, depending on the last assignment dose for the extension or shortening. But about the 2 milligrams, it will be switched for the 8 milligrams. And it will be, after receiving one injection of 8 milligrams, it will go directly for interval of Q12. And then one point will be after 1 year. I just mentioned it. And if you go here about how they will compare, shortening will be different than the others. The shortening and extension will be by 2 weeks for the arm from switch from 2 milligrams to 8 milligrams. And the criteria for extension and shortening is again here is around the same as the previous, but to put in your mind that the baseline here got some difference as the patient in the end of the second year, it will be depending on the mean result between 84, 88, 89, and the patient after receiving the first injection of 8 milligrams, the patient will be observed every 4 weeks. Then after that will be every 12 weeks. I will not go by this patient disposition and characteristics. But just number of the patient is very important to understand that how much number of the patient who entered the study can he receive the number which enter the extension. It's around 70 in the from switch from the 2 milligrams to 8 milligrams, and around 190 continue in the from Q12 and Q16. Just to go for the visual acuity and the changing the mean best correct visual acuity, you can find by the end of the study that around you can see the stability, no difference between the overall readings. And if you go in depth to compare between the 8 milligrams Q12, Q16 by the patient who switch from the 2 milligrams to 8 milligrams, we can found that in the third year that around the same number of letters is the stable. There is no difference or reduction in number of letters which already gained. Again, here that just we that the patient when switch from 2 milligrams to 8 milligrams, a reduced number of injections, around 4 injection, comparing by the second year and the first year. Again, go to in depth about the retinal thickness, comparing between the photon and photon extension is around the same. If you go from here, from the end of the second year to the third year, you can find the readings around the same. But if you go in depth to find that the patient, after he received the 2 milligrams, he received the 8 milligrams after the first dose, there is significant decrease in the central retinal thickness around 50 microns. And this is sometimes even we notice in our real life when I just offer some cases now, just will found that sometimes the patient will receive that the 8 milligrams, there is really a dryness effect, which could be the maximum effect. Need to be to study more in details in the futures. Again, the patient is after he switched and so after receiving the 8 milligrams the dose, then extension every 12 intervals will be every 12 weeks. We can find that the patient stable and there is slow reaccumulation of the fluid after the 8 milligrams. Again, last about the extension study, you can see that about the number of the patients, the proportion of the patient who reaching the Q20, you can find, depending on the last completed dosing intervals, around 40% of the patient, they are more than Q20. And again, the last assigned dosing interval, this means the patient was supposed to go for the Q20, around 48% assigned for Q20, around 70% in the two arms, more than Q16. So even the patient who switched from 2 milligrams to 8 milligrams, 83 with these patients, the last assigned dosing for them was more than Q12. Safety profile, the most important thing, just as you know that the safety profile, there is no, it was the ocular, non-ocular for the AMD, it's acceptable. Intraocular inflammation, so there's no case of endophthalmitis or retinal vasculitis. Intraocular pressure, because the dose of the size of the dose around 0.07, so there is no any reports about increment the increase in the intraocular pressure. Again, in the DME, there's the ocular intraocular side effects acceptable. No intraocular inflammation, no vasculitis. Intraocular pressure, even the increment was around 1 mercury micros through the week 48. And the ocular safety, even in the extension, was acceptable, not ocular, non-ocular. And so by end of this photon, just we mentioned that around more than 45% of the patient who completed the study was assigned for Q20 weeks intervals, and around 48% of the patient assigned for who assigned at the end of the study was more than Q20 even. And the patient who switched from 2 milligrams to 8 milligrams in the last year, it was the visual anatomical was acceptable. And with the decrease, as we mentioned, the decreased number of the injections, 83% of the patient achieved more than the Q12 in the switch arm. And this is that it could be given evidence that it could be the 8 milligrams in the futures have better in the dryness comparable by the 2 milligrams. And the safety profile for the 8 milligram are acceptable comparing by the 2 milligrams. And I want just to share some few cases from our hospital. Already received the aflibercept 8 milligrams around 3 months back. So most of our cases now we use it maybe more than 60, I think, or 80. Most of our cases just patient who was receiving the other anti-VEGF or aflibercept 2 milligrams, they switch. And we have some naive cases, and I will just review some few cases of naive cases. You can see here a gentleman, 55, diabetic, hypertension. You can see on the left side here that the patient has a reduction of vision on the right eye, and the left eye is the edema, but the vision was acceptable. He received the first injection of the 8 milligrams. I can feel the result was acceptable. the left eye was the worst thing happened. So the patient received the right eye and left eye injections, and you can see the result here. Still there some intraretinal fluid. We give him the third, finish the loading dose, and the patient has excellent result after 3 injection right eye, 2 injection left eye. Again, the second case, a lady here, 62 years, diabetic, vision right eye 0.7, left eye 0.8. You can find here that the patient has the intraretinal fluid. And when she received the first Eylea 8 milligrams right and left, you can see after the first injection, the patient has excellent results. I want just to share one of these cases. This is my patient because I know him. So the patient, he is 65 years. He has right eye CMVM, received wasn't 2 milligrams before, and between extension here. But I find that the patient, after he receiving the injection, after the last injection from the 2 milligrams, still there is intraretinal fluid, and you can see the membrane here, and there's some residual retinal fluid and intraretinal fluid. And after he received here, we decided for him to try the 8 milligrams, and you can find the fantastic, excellent result. You can see the membrane dies, and there is no subretinal fluid and intraretinal fluid, except the patient vision was around 0.9. And then in the end, I want to thank you to be patient to listen to me. I hope that if there is any question, then we can discuss about the result of these studies.
Thank you very much, Dr. Hassan, for this excellent presentation. I think there is many questions. We will hear it if there is anyone from colleagues here in the panel, Dr. George or Dr. Jacob, Nabil, anyone or other colleagues also. Anyone want to ask Dr. Hassan any questions?
Dr. Hassan, excellent presentation. Congratulations.
Thank you.
After all this good result that 8 milligram brings for us, nowadays in your side, your hospital, what is the number, I mean, percentage of patients that are switching from 2 milligrams to 8 milligrams in nowadays? You have many patients that really wants to switch this, or many patients say no, stay the same with the 2 milligrams.
Thank you, Dr. George, for the good question. For us is that in our hospital, we are governmental hospitals. So the option to have the 8 milligrams, just we offer them that we don't need the 2 milligrams. So now we don't have 2 milligrams anymore. So all of our patients should go for the 8 milligrams. And so
100%,
most of our
8 milligrams, 100% now are using 8 milligrams. And
since the 3 months, we use the 8 milligrams.
And the numbers of the extension is following the trials. I mean, you have 80% more or less with 12 weeks, and 40% more or less gonna be for 20 weeks extension. You think that it's quite the same?
Dr. George, let me speak frankly and honestly. For us is that still, as I said, for you, November, we received the medication as a stock. So still, even the patient didn't, the few patients who finished the loading dose. But if you ask me about who switched from 2 milligrams to 8 milligrams, we have any negative feedback? No. Most of the patient, as I said, this is my patient. I give him the injection. It was very nice. The result was excellent for me. But about the extension and going for 12 weeks and 16 weeks, in our hospital, even before that, yes, we assign the patient for 3. We like that we wanted to reach this 12 weeks and 14 weeks. Better for us for the burden of the case, especially we have sometimes busy clinics. But we give the patient, and after the loading dose, we give him like appointment. We assign a loading dose like 3 months, but we give the patient appointment with us after 2 months. Then we can, if there is any, we can manage the case before.
Every patient that you switch, you do the loading dose. I mean, 3 months injection, and after that You
When
try to extend or not?
yeah,
You,
we are يعني strictly going with the loading dose if the patient respond wasn't يعني acceptable. But if the patient يعني dry after the first injection, mostly we go by the extension. Mostly even after the photon extension give us this option directly, and now after you if you go for the photon extension, you find that after they receive switch from 2 milligram to 8 milligrams, they receive one injection for 8 milligrams, then they go for the 12 weeks and the shortening and the extension depending on the maybe the results.
good. Thank you.
Any other, Dr. Nabil, you have any comments or questions?
Actually, Dr. Hassan answered my question. So I wanted to ask if we have the two medications and at the same price, would we go still with 2 milligrams, or yeah, is there still room for 2 milligrams, or we'll go straight for 8 milligrams? So as Dr. Hassan said, I think if the two are available with the same price, we'll go for the 8 milligrams, right?
Yeah, for us as Dr. Nabil, as he mentioned that can respond for that. It was like why we reach this equation. I prefer that you have all the options for the treatment with me and my colleagues. But because of the pharmacy policy, then I said we discussed with our colleagues that why we need the 2 milligrams. If we have the 8 milligrams, if you wanted the 2 milligrams, you can adjust the dose because this 0.7. So I think you can manage it by to acceptable. If you are strict to 2 milligrams, for us, we said we don't need 2 milligram anymore.
Dr. Jacob, I think you have something.
Thank you. Thank you for a most informative talk as well. One of my concerns when looking through the data was that the criteria for shortening is actually 10 or 15 letters of visual loss. I wonder if when we are looking at our real world experience, would we be happy with a patient losing 3 lines of vision before we go for shortening, for example? So when we are looking for a non-inferiority trial, we may have some room to play with to make sure that it's not inferior. But in the real world, I think most of us would not be happy with any patient losing 15 letters of vision before we retreat. So would that be a concern in your extension trial? Would you be willing to wait for a patient to lose 2 lines, 10 letters, or 3 lines when we extend the follow-up to 4 months?
Yeah. Thank you, Dr. Jacob, for this good question, because even this is in my mind when I review all the data, that how we accept it. But 15, I think the 15 letters in the extension, because they manage going from 2 milligram to 8 milligram. Even the assigning dose, if you go in detail, it was comparing by mean for four letters. You know that you wanted to approve something when you switch for the other. But in the photon and the pulsar, even the number of letters is not acceptable. The 5 letters and even the microns is 25. So just and. But in the diabetes 10 letters, I think even in the study, this is that this is for to take approval for the medication. They was observing the patients every month. All the 2 years, the patient was observed monthly. So it was, and most of the patient, around 90 of the patient, reaching the extension. I think in the photon study, reaching the extension around 90, the extension for more than 93, more than 12 weeks. So yes, still there's patient maybe will not respond well as you expected. Then here's the job of the follow-up or the doctors, that how he manage from after the loading dose, how you check the response, how the patient reach there. As I said for you, we have some tricky. We learned from the previous medication that we bring the patient to be examined 1 month before, or 3 weeks before, 4 weeks, and do OCT. Then according to that, we manage the plan for the patient to avoid any decrease in the vision. For just we don't play the trial role here. We play the real world role for the patient. We want to advise them.
Thank you, Hassan. Is there any other ones from here, colleagues? We have one question from the attendees. There is, do you prefer to start loading dose with 8 milligram and treat and extend with 2 milligram in the opposite side?
If I said for you, doctor, it was clear. Even I think that the company wasn't happy, in spite of they are with us and sponsoring us, wasn't happy that I tell that we don't need the 2 milligrams anymore. I feel that the 8 milligrams there and the rule there for the 8 milligrams to approve it. How you will approve it if there's you have competitor 2 milligrams in spite of, unless we have an evidence that the 8 milligrams is not, there's issue in the safety, and this is didn't come within the within 3 years. So I feel that in our hospital we are happy now with the 8 milligrams there. We don't even regret that we lost the 2 milligrams. Maybe we lost the pre-filled. Just we hope that they will have the pre-filled very soon.
Okay, Dr. George, I feel that you want to say something. Yes.
Yeah, I'm really happy to hear everything about the hospital are using 100% 80 milligram. You can really collect data for real world study, because if you have so many patients together using only 8 milligrams, and will be a very good for the community to know how the behavior of the drug, the disease, and everything, because we have a lot of data from the trials. That's good, but now you and your hospital are doing real world, how the patients, the disease, and everything. I feel that's would be wonderful to know that the patients are very happy. The drug really dries a lot, and you have almost 50% of the patient with more than 3 months to repeat injections. That's gonna be very nice. But congratulations! I'm really curious, because here in Brazil, I don't think have any institution that's using only 8 milligram right now. That's pretty nice, because you have the best of the drugs in your hands.
Thank you.
It
We
will
hope
be
that
soon. You have to work for that, George, to have it soon.
Yeah.
Okay. Dr. Hassan, there is another one question before I start my questions. Volume for both 2 milligram and 8 milligram, is it 0.05 mil? The same?
the 2 milligrams 0.05, but the 8 milligrams, the molar size is more, but and merely 0.07. You inject 0.07.
Okay.
And here's the issue about the intraocular pressure. Even for us, we focus on the intraocular pressure for the patients, for all the patients. Mostly, we check the pressure after the injection.
Okay. There is a question, Dr. Hassan. I mean, if you are starting with a naive patient, you will start with a loading dose. But if you are switching, you can either continue as a loading dose, or you can do a PRN and check.
Doctors, that about that, the practice in real life, I explain the study. But if you come to my real life, even if you go for the real world data, most of the there's no one strict for the loading dose if the patient is one and is happy. So for me, even the patient, I speak frankly, if the patient is that we have the luxury, the patient can receive us. The patient after the first injection reach one dry, I will not advise him for the loading dose, if you speak frankly. But if the patient is has edema, like if you saw my cases, it's clear that was dry, but the patient still, there's some retinal, I give him loading dose, finish. I want him to be dry, then I extend him. About switching from 2 milligrams to 8 milligrams, I think that if the patient become dry, you can extend him. There is evidence that you can extend directly. Why you don't use it? And I can observe the patient as I wanted, monthly. Just to put in your mind, the patient who received the aflibercept 8 milligrams after the switching from 2 milligrams was observed monthly for the 3 months. Then
Okay,
he
this is
received
another question, that the follow-up is different than injection. That we have to remember. So you can bring the patient to see and follow up according to your wish, but it doesn't mean that there will be an extension for 3 months or 4 months, or even we'll reach up to 5 months when we are going to 20. But the follow-up, it can be every 3 months, every 2 months, whenever you think, until you are satisfied there is nothing is happening with the patient, right?
But always, I think that if the patient naive and he came and diabetes, and mostly the patient, the loading dose will make the patient better in the follow-up situation, better than inject him, keep him follow-up. Like I feel that you should control the retina totally, then you can extend the patient to follow.
Okay, another one question from Dr. Nasra Al-Habsi, dear colleagues from Oman. It is an always asked questions, starting with the strongest or latest drugs. Make it hard to go for another drug. Your comments?
Um, uh, I don't get the question clearly. That shifting from another medication or just
And
from the
whenever you are facing a new molecules or any drugs,
yeah,
sometimes always you will feel, okay, you are hesitant to
As
start
I,
or not
as you said,
strongest.
the aflibercept was for us from before 2 milligram was the safety profile is good, and the study approved the rule of the 8 milligrams. And for that, we wanted to give the chance for for the medication clearly in our hospital. So for that, we take the decision directly to switch for the two.
Anyway, Dr. Hassan, there is a lot of question in our mind, but we are behind the time. So if there is any question at the end, maybe we will can have more further discussions. So now we will go directly to our colleagues and we will start with our young ophthalmologist competition. And I think we will have now the first one is Dr. Borso, and she is a specialist at Tibeki Training and Research Hospital.
Good evening.
Good evening.
Can you see the screen clearly?
No, you didn't share yet. We cannot see.
Mm-hmm.
The presentation should be opened and then share the screen or available in the desktop, please.
Mm-hmm. Can you see now?
No.
No, we can't.
Maybe you can continue with another
Okay, we can
person.
start
So
with
I
another
can
colleague.
arrange.
Yeah.
Okay? Mm-hmm.
So
Thank
we
you.
will have Dr. Muhammad. If you can share your screen, Dr. Muhammad Saad also, he is a resident in ophthalmology from Pakistan. Dr. Muhammad, the floor is for you.
Hi, Doctor. Thank you for the introduction. I'll now be sharing my screen, so I hope that you guys will be able to see it. So it's a video, so I'll be sharing the video here. Can you see it?
Yeah, we can see your name. Okay, you can now. Yeah, we can see the video. Okay, you can start.
All right, just give me a moment. I'm just about to start it all up. All right, are you able to see the video now?
Yes, please.
All right, great. Thank you for the introduction yet again, Doc. My name is Dr. Mohammad Saad. I am a fourth year resident currently working in the Retinal department here in Al Shifa Sai Hospital, Rawalpindi. So the topic of my presentation today is I'm presenting a surgical video of mine on the techniques of iris suturing and iris repair in a traumatic case. So this patient was a 30-year-old male patient. He was presented with a history of trauma to his right eye. Preoperative examination revealed a paracentral corneal laceration with a traumatic cataract and a defect within the iris. The patient initially underwent a primary corneal repair with lens matter aspiration and implantation of intraocular lens, and later on his iris repair was planned and performed. The iris defect was triangular in shape with the apex leading towards the pupil, and it had a distal and a proximal end. So whenever we are suturing the iris, so there is one thing which I always tell my juniors and also my fellows is that suturing an iris is like threading a needle while you are wearing boxing gloves. So that's why planning and the right instruments are everything in this procedure. So for that, I have got a micro forceps in my left hand for the traction on the distal iris defect, while traction from the other end is by sharp end of a 90 Prolene sutured straight needle. So, well, some surgeons they also prefer curved needle for that purpose, but the problem with the curved needle is that it lacks the length to pass effectively from limbus to limbus. So that's why a straight needle is usually preferred by the surgeons. So once we have got our instruments ready, the next thing is to create the paracentesis or the incisions. So for that, your go-to mantra should be preemptive planning. The incision placement should be strategically placed, keeping in mind that needle trajectory should be as perfectly done as possible. Like in this case, I traced the needle over the cornea to identify the path or the trajectory taken by the needle and placed my paracentesis at 11 and 7 o'clock hours. So once we are done with the paracentesis, now we are going to pass our needle, and for that we have to take the bite of the iris stroma. And it's the taking the bite. It's just like trying to thread a needle while someone is shaking up the table. So that's why yet again careful planning and as from where and how to pass the needle is really important. So specifically in this case, just mind the proximal and distal ends of the iris defect and the sides of the piercing. If it's too close to the iris margin, it would cause cheese whiting. If it's too far, it would crumbling up of the iris, leading to a peak pupil. So roughly, what I normally do is that I pierce the defect of the distal and the proximal ends roughly around 0.25 to 0.5 millimeter from the iris defect margin. So we have to be very careful in this particular part because one wrong move and you're either crumpling up the iris or you're making the pupil look like it's winking at you permanently. So, and trust me, patients don't usually appreciate that kind of personality trait in their eye. Just for that, we will enter above the defect, iris defect, and will exit below it. And once we had completely passed through both the distal and proximal end of the iris through our needle, the next step is to withdraw our needle from the other paracentesis or other wound. And for that, yet again, we have got our famous and most accompanied friend of ophthalmic surgery, which is viscoelastic. So we'll have to inject a proper viscoelastic into the anterior chamber so that the anterior chamber deepens and the needle doesn't get stuck in the decimate membrane, so it doesn't cause any further complication and it gets a smooth withdrawal from the other paracentesis. So just like that, I am smoothly withdrawing my suture from the other paracentesis. And here, with the help of dotted lines, I'll show you the initial part taken by our initial suture. So once we have got the suture out from both the paracentesis, the next step is to tie a knot. And tying knots in such a small face, it really feels like performing microsurgery on a mosquito. But fortunately, with good technique and good planning, we can avoid creating decorative knots that just confuses everyone. So we have got this game-changing Siebes's knot technique. So for Siebes's knot, what I did is we'll have to take a loop-like instrument, a hook-like instrument, sorry, to take a loop out of one wound. And for that, I am taking out, I'm using a dialers initially. So I took a hook-like instrument, which is dialer in this case, to draw the distal end of the suture outside of the 7 o'clock paracentesis. And just like that, I've got a whole loop outside one of the paracentesis. Yet again, I'm drawing the current position of my sutures. In blue, you can see the initial length of the suture, and the green, the loop which I have taken out with my dialer. So we have got two limbs of the loops, the ascending limb and the descending limb, and one is the externalized end of the suture, which is coming out from the 11 o'clock paracentesis. Now what we'll have to do is we'll have to pick one limb. I mostly pick the descending limb. I pulled it out of the loop and I tighten the externalized end and pull it so the knots goes into the eye and our first throw is completely done. And yet again, I'll reorient the suture for the second throw in the exact similar fashion so that proper approximation of the iris defect is done. What I usually perform for the throws is I usually go for 3 to 4 throws to ensure that we attain proper approximation and security of the iris defect and we don't get the iris crumpled up by putting on more throws. initially my plan was to go into one direction with the needle, that is entering from the 7 o'clock hour position and exiting from the 11 o'clock hour. But I kept reassessing the defect using microforceps to see the expected shape of the pupil. And if I had gone for the same direction, that is 11 to 7, the iris actually in that case was not that healthy because it was a traumatic case. So I felt the pupil will become more eccentric or keyhole shape if I have gone through that pathway. So yet again, the preemptive planning somehow kicked in at the right time. So for the second bite, I took it from the opposite direction to maintain the anatomical roundness because no one wants a pupil to look like permanently surprised. And when I took the second bite from the 11 o'clock incision and took it out from the 7 o'clock, I reoriented the suture in the very exact similar fashion. While the suture's orientation was 180-degree reversed in this. So we have got the loop come out of the 11 o'clock incision and the initial suture going through the 7 o'clock incision. So yet again, with a very similar fashion, I'm going to tie the knot for the first throw, and like that, I will perform 3 more throws to get the proper approximation done. Now, while tying the suture, you have to be extremely careful that if you get it too tight, you get crumpling up, and you get it too loose, the iris might just decide to do its own thing. So basically, it's a bit like adjusting a necktie. If it's tight enough to look sharp, but not so tight that you regret all of your life decisions. So with that, throughout the procedure, I made sure that eccentricity and the anatomical roundness of the pupil stays the same. I have gone for about 4 throws to secure each set of the defect. And in the end, after doing each of that throw, I have cut the suture end by micro scissors. So to summarize the iris suturing technique in 3 words, it would be number 1 is preemptive planning. Number 2 is precision in the needle handling. And number 3 is the proper suture placement. And if we make sure that all the 3 boxes get ticked for proper approximation, we'll have a good result in the end. So currently, this patient is recovering well and is under keen observation from our department, and we are expecting a good visual rehabilitation. Hopefully, soon he'll see how much of the effort went into giving him a perfectly round pupil, because trust me, making that happen took me more planning than my last vacation. So that was all from my end. I really appreciate any questions from the audience.
Thank you very much, Muhammad. This is very nice and very excellent, showing how you do the technique of iris repair. If there is any comment from any of our experts here, Dr. Hassan, George, or Jacob, and Dr. Nabil.
Dr. Assad, very nice surgery. I really appreciate that, and have some questions to really understand well. You use the looks like you are using 10 zeros per lane, and then how you tie the knots, and the knots stay up. I mean, because you need to be upside down to be less. I mean, you finish in a very elegant way. I mean, and the inflammation after all this, it's how you handle, and how bad is the inflammation after you touch too much the iris.
Thank you, Dr. George, for the appreciation. So I'll divide the answer of your question into 3 parts. So the first thing is that I used 9-0 proline in that case, not 10-0, because 10-0 was not available in my institute. So the thinnest was of the 9-0, so I used the 9-0 proline. The second thing is that to make sure that the suture doesn't get up, what I usually do is that I enter from the superior portion of the iris and then exit below it. So in that case, it really, I really make sure about that the suture doesn't get out of the way with that. The third thing is the post-operative inflammation. Yes, with that kind of manipulation of the iris, this thing is something which we, can't really eradicate in any opinion. So that this is the reason why what we did here was that we didn't do the entire surgery in one setting. We initially did the corneal repair and the lens mat respiration, and after 3 to 6 months, what we did was we planned this surgery in an elective procedure, and post-operatively we put the patients on steroid, and we had him on a close follow-up to see any signs of inflammation or any persistent signs of inflammation. So yeah, this was all for that.
I think we can stop here because we are running behind the time that's supposed for Dr. Muhammad. Thank you, Dr. Muhammad, for this excellent presentation.
Thank you.
And we can go to the next speaker. Are you ready, Doctora, for the presentation?
Maybe I can try again.
Yes.
Mm-hmm. Can you see now?
Unfortunately, no. So I will advise if you can communicate with in the group with
Yes,
Abdullah.
okay, I will.
And give him the permission to have control your computer, then maybe he will help you. So we can go now to Dr. Siddhar Manju, please.
Good evening, sir.
Good evening.
Good evening to all members of this esteemed panel.
And just stop, mute yourself, Doctora, please. Okay, now, sorry, yeah.
I'll start my screen sharing.
Please.
Is it visible?
Yeah, we can see your name. Yes, now you can go ahead, please. Yeah.
Fine. Yeah. I'll just put it in the presentation view and I'll just minimize. Yeah. Okay. Good evening to all. I'll be presenting on the management of refractory macular holes. These 4 cases that I've put the images for will be the backbone of my presentation. These macular holes were of large size. The macular holes were associated with myopia and were traumatic in nature, and hence they were refractory in nature. We used a free iLem flap transplantation, macular hydrodissection, and neurosensory graft technique out of the multitude of options available for achieving macular hole closure. Usually the main problem encountered in these cases is that the ILMP has already been done. So there is no paramacular ILM. So in the first case, what we did is we took ILM from elsewhere, as has been shown in the subsequent video. We start with the staining of the ILM. We see that the paramacular ILM has been peeled already. So the ILM autograft from elsewhere or the periphery has been stuffed into the macular hole, which seems to be adequate. So we take another piece of tissue and stuff it into the macular hole to close it. This is followed by fluid air exchange, and at 3 months, we see macular hole closure. Sometimes ILMP fails in cases of very large holes, and it is also difficult in cases of scarred retinas and myopes. So what do we do? In this case, we can just bring the edges of the macular hole closer to close it, which can be seen in the second case. Here we see a 41 gauge cannula being used to induce macular detachment all around the macular hole circumferentially. What this does is it makes the retina mobile, and the fixed edges of the macular hole become mobile. Thus, when we do the FAE, the mobile retina helps approximate the edges of the macular hole, and hence at 3 months we achieved macular hole closure. And finally, I come to the neurosensory graft technique, which is a good technique in cases of macular holes that are stiff, and in which we aim for better post-op visual improvement, and we are not satisfied doing the above mentioned procedures in the refractory holes. What we do is we take a retinal graft and fill it in the area of retinal defect, as has been shown in this video. We do diaphthermy to the edges of the graft site. Then we circumferentially do endolaser. Then using the 41 gauge cannula, we detach the retina and cut the graft within the site of the endo laser. Then we put in PFCL and slide the macular graft by overlay technique. Then we do fluid air exchange. And at 3 months, we see the macular hole as closed. Now, this neurosensory graft technique is a very versatile technique, and it is found as a very good option in cases where macular holes edges have fibrosed, such as in the cases of trauma. So this is one video depicting that. We see that the edges of the macular hole are fibrosed. Hence, again, we proceed in the same way. First, detaching the retina, then doing endolaser to the edges, then cutting the graft of appropriate size, then injecting PFCL, doing endolaser to the edges, and sliding the graft carefully over the macular hole by overlay technique. Then after fluid air exchange, we close the case. And again, at 3 months, the macular hole is closed. Now, the neurosensory graft technique is a very versatile technique. It helps by acting as a scaffold. It also has a property known as ectopic synaptogenesis. It also acts as a progenitor for photoreceptor cells and provides innate retinal structure, which helps in the retinal layer closure. In a limited case study in our own hospital of 21 patients, we used neurosensory graft technique and achieved 100% macular hole closure rate and achieved a visual improvement of 6 by 52 Snellen's units from 6 by 165 Snellen units. Thank you.
Thank you very much, Dr. Siddharth Manju for this excellent video show and excellent result. I think I will leave this one. Nabil, I think he will ask because now the vitreoretinal surgeon will start asking about these things. Okay, Dr. Nabil.
Yeah, thank you for presenting these great cases. So for let's start from the last one for the retinal autograft. I saw you were pulling the autograft with one forceps. Usually I would go for two forceps to maintain the upside down of the autograft. How do you make sure that this autograft is not flipped when you move it with one forceps?
So actually, reading many articles, I do agree that bimanual technique is a very safe way to do it. But in our hands, we've done a few cases, and even using a single forcep has worked well for us, and it hasn't slipped yet. So I think in our hands, it works well. So yes, I do agree with you that bimanual is a much safer way.
Okay, another question, please, regarding the first case where you put a free graft from ILM. So how did you guarantee that these free ILM grafts did not float with you? You did not implement them under viscoelastic or under PFCL, right? Or you did?
Yes. No, sir. No, we did. We didn't do that. We didn't do that. Yeah.
Yeah, the problem here, these small pieces might float and you cannot catch them
Yes, I
again.
do agree that the jetor fluid from the infusion cannula does sometimes make the graft float, but then I mean, it's a matter of practice, sir. I mean, in some cases, we've also used viscoelastic, put it over the hole and just slid the uh, ILM graft over it, and it has helped, yes. But then, in this case, as the video is in front of you, it was a very controlled maneuver, and it helped. Yeah.
Yeah. Thank you.
Yes, sir.
Any other comment or questions? Dr. George or Jacob, please.
Very nice presentation, Manju. You present three techniques for persistent macular hole after surgery. And the first one that was common, the free flap, is something that I do sometimes. And for not flowing the flap, I think the very important to shut down the infusion,
Yes,
because you can't have any flow inside the vitreous cavity, and sometimes the size of the flap matters not to flow. If you put a very small flap, usually they flow more than something a little bit bigger that you can accommodate. But I usually not to stuff too much, because it's dangerous to touch the RPE, and you can have a closed macular hole, but you cannot get good vision because have a geographic atrophy in that area. That's because you touch too much. And then I tried just to accommodate the flap, not to really stuff. And the other trick is the fluid air exchange has to be very slow, because if you put so much movement in the vitreous cavity, they're gonna flow again and have to start again. And then sometimes it's good to use viscoelastic. If they flow first time, just accommodate and put some viscoelastic over the flap. They're gonna stay well until the end. And the other thing, I don't have experience, the one that you just inject subarachnoid BSS. I know that have friends like the friend from German that's use a lot this. And the last one is the autograph. The autograph, I think, is very good technique when you have big holes, more than 800.
yes.
And this one is very tricky, because sometimes it's like Dr. Hafka said, how to, not to flip it up. The two hands by manual techniques is more safe. And the other thing is where to choose the place to harvest the graft. In my hands, I try always to be in the up position, because more easy to up down the flap than to go for temporal to nasal. You need to be not to be too far from the hole, because when you have long maneuver, and you can you have to be very careful not to really be so aggressive, because you can lose photoreceptor. We really don't know if this photoreceptor in the graft will recompose the area and gonna give good vision. But on the other hand, when you close the hole, you get better, because all the surround area of detachment, you're gonna flat, and you're gonna have vision for that area. That's a big discussion. That's if this graft can really give some photoreceptor that's gonna survive. We don't know, but very good. Congratulations.
Thank you very much.
Thank you very much, George. Is there any other comments? Just we need a very short, if there is anyone. Otherwise, we can go to the next speakers. So I think we'll go to the next speaker. Okay, we can share the screen. Okay.
Okay. Yes, this is my video, and it has the voice, so I will just open it, okay?
Start the video.
Maybe they will start
Allah,
it.
can you start the video, please?
Hello, my name is Dr. Burcu Işık, an ophthalmologist from Istanbul. Our patient had a soft, painless nodular mass on the lateral side of the upper eyelids bilaterally. This made us suspect lacrimal gland prolapse. We performed lacrimal gland repositioning combined with an upper blepharoplasty. The nodular mass was seen laterally and dissected. The superolateral orbital rim, was also dissected. Lacrimal gland normally stays under the superolateral orbital rim. After the careful dissection, local anesthetic was injected under the capsule of lacrimal gland. Afterwards, 5-0 purulent suture was passed from inferior part of the lacrimal gland, then superolateral periosteum of the orbital rim. Purulent suture doesn't cause any inflammation, so it's chosen for a proper position. Number of the sutures depend on the size of the lacrimal glands. When we were sure that lacrimal gland is in its anatomic position, upper eyelid blepharoplasty was completed. Thank you very much. I'm not sure if it's relevant with this
Yes.
meeting, but it's about oculoplasty.
No, it's great, great things that we hear about. Okay, is there any comment from our colleagues here? Anyone in George or Dr. Hassan, Dr. Nabil, Dr. Jacob? So anyone want to ask Doctora about
My
this?
child was excellent surgery, and I hope that one day I will do that.
Thank you very much.
Okay, any question for Doctora about, because all here the expert, they are away from the oculoplasty, but oculoplasty now is one of the fan and it become also very famous, doing a lot of things. And what you have shown is something I didn't see it before. So to be
Yes,
honest,
it can be it can be mixed with the fat tissue. So oculoplastic surgeons must be very careful during upper blepharoplasties.
okay,
Yeah.
how can you differentiate? What is the way that you can tell that you are dealing now with a lacrimal gland or it is a soft tissue, not that?
It's nodular and pink, more pink than the fat tissue. And its repositioning is very important for tear production and ocular surface health. So I sent a oculoplasty video, but it's, I know, a retina symposium. But I
No,
think
it's okay. It's great. It's open for anyone. I mean, but there is another thing that we usually, I don't know if other colleagues knows or they can correct me if I'm wrong. Protrusion, we are feeling that they are the nodules or the lacrimal gland go inside below, directly below to the, I mean, we are having two parts of the lacrimal gland. And most of them, when there is something like that, they go not outside, but it go inside in the, to the conjunctiva side like this from inner side. But we feel that this protrusion is going out.
Yes, there was a swelling in the
Yeah.
lateral side of the eyelid.
Okay.
It was a little bit suspicious. When I opened the skin with a little bit dissection, I showed clearly the lacrimal glands in both sides.
Okay, there is any maneuver to tell? I mean, you can, I mean, roll up or invert the eyelids up and see if this is, because we usually thought that when we want to check for the lacrimal gland, you have to invert the upper eyelid and ask the patient to look to the nasal side, and then you will see the rim of the, lacrimal gland on that area. Are you doing this maneuver before to tell, or it can give you a hint about this? Or?
I did not did it, but I will search about it.
Okay.
No, I did not perform it.
Okay. Any one of our colleagues, any vitreoretinal have an idea about oculoplasty?
One day I want to
George,
learn that. It's too much to me.
Let me explain for you. One time I entered the OT, the minor OT. We have minor OT sharing with the oculoplastic. So I entered with them. They was injecting the Botox. So I think that they injecting Botox. So I stand up behind them. They make puncture for the skin. 15 seconds like this. I tell them that I want to release myself from the VR and I want to be with you. for the
Yeah.
Botox.
Yeah, because you are looking for the buttocks. But if you are
No,
looking
no,
for
not
removing the
looking Botox.
cancer
The easy,
or removing something else, it will be very
the,
difficult.
it's very easy for me. It look for me. It's very easy. Somebody just punctured the skin from outside and around the orbit. I said it's very easy. Better than the 4 hours retina.
Yeah, but sometimes they are spending 3 or 4 hours. I mean, especially if they are having any mass,
Yes,
they are
orbit.
removing
Yeah.
sometimes even the bone, cutting the bone, and then they go to see. Sometimes they are go behind the orbit to take any mass or something like that. I'm correct.
Yes.
Okay. Anyway, thank you very much. It was very nice, very short,
Thank
very
you.
informative, and it's a very good message for us to learn
I
from.
had a PowerPoint presentation too, but you know the technical
Yeah, I
problems.
think no,
So,
it like this is more better. I mean, this is a very
thank
nice
you.
showing the things directly. So we learn all the information, all the message they want to send in just 2 minutes or less. That is
Thank
very
you.
nice, excellent.
Thank you
Thanks,
very
thank you,
much.
very. Thank you
Great.
for all our young ophthalmologists and congratulate all of them for this great presentation. We will have one video small show, then we will go to our expert presentation and we will make it very fast. Everyone 2 minutes and a half. Yeah, I'm just joking. No problem. You can take 3 minutes.
Calling all young ophthalmologists. MEOM webinars, your chance to lead the conversation. Experts in the field will evaluate and declare the winner of the young ophthalmologist in the competition. Here's how it works. Young ophthalmologists compete to get 3 talks, 10 minutes in the monthly webinars. Why join? The top 3 winners will get free registration and accommodation for the 7th MEOM conference. Don't wait. Submit your work to be a presenter at the MEOM webinar in 2025. Apply now.
Okay, thank you very much for the management events. And now we can move to our expert and we'll start with dear colleagues and Jacob Shaku, and he is the head of retina service, UDB, Mangalore, and Kasar Good. So he will give a talks and we are waiting to hear from him and his experience. Dr. Jacob.
Thank you, thank you. I think due to shortage of time, I think I shall just stick to one presentation.
Yes.
Because I think we don't want to if I'm given 3 minutes, I think if I can have 6 minutes for this presentation rather than 3 minutes for each presentation, I would be very grateful. Thank you. I hope everybody can see the presentation.
Yes, go ahead, please.
Okay. Let me just. Sorry, 1 minute. Yeah. So I think I'll just stick to the surgical topic with the video, so it'll be more interesting for everybody. Submacular hemorrhage is a catastrophe because only 1 out of 10 patients regain 6 out of 6 by 60 vision. And, it can be classified according to size. And we are talking about, I'd like to focus more on the patients with large submacular hemorrhages. So anything within less than 2 disc areas is small, more than 2 disc areas within the arcades is medium, and outside the arcades, if it extends, then it is considered to be a large subretinal hemorrhage. So most submacular hemorrhages are due to neovascular AMD, but especially in India, we see a lot of patients with IPCV, and RAM and myopic CNVMs are taking up a few of the cases. But I'm going to quickly go through this. I'm going to skip through this because of shortage of time. Just one thing, sometimes when you have a very large, when we talk about large subretinal hemorrhages, sometimes we get confused with a melanoma in a picture like this. Of course, we can see the features of age-related macular degeneration, but an ultrasound will show a retraction cleft as well as other features regarding the location. with melanoma being more posterior. So what are the treatment options that we have? We can give anti-VEGF alone in small cases, in cases with small bleeds, anti-VEGF with pneumatic displacement, with RTPA, and PPV with RTPA. You give it the RTPA under the subretinal space, put gas and anti-VEGF as well. What is the advantage of anti-VEGF alone? It's easy, but it's got poor outcomes in thick bleeds. Pneumatic displacement, it's got a faster resolution. It has displaces thick blood and allows anti-VEGF to act on the lesions faster. But the problem is that it can cause photoreceptor damage, requires positioning, can cause shear to the photoreceptors, and of course, cataract and glaucoma, retinal detachment. There's an unusual, as we can see, that many of these cases have an unusual extent of number of patients actually developing retinal detachment as opposed to other pathologies that we do a PPV with. So quickly go through the cases. This is a patient with PEHCR, with a peripheral exudative hemorrhagic retinal chorioretinopathy. And you can see that I've just observed this patient. This patient was 6x6. I observed it and then I applied laser to this patient. 6 months later, the polyps after laser have regressed. Again, traumatic subretinal bleed, sometimes if they have got good vision, nothing needs to be done. What about pneumatic displacement? We do not know with RTPA, we do not know the exact safe dosage of RTPA, but we consider that 25 micrograms is the most usually acceptable dose. And what is the advantage of doing a PPV in these cases? Because we are really delivering the drug to the subretinal space. The biggest problem with this is that we need to wait for a very, very, very long time, and we don't like waiting as retinal surgeons. So what happens is that you need to actually stop the surgery, inject it, maybe actually take 40 minutes. You're not going to be sitting on the same table. You need to put the plugs and probably step out. It needs at least 20 minutes. But the outcomes in very large subretinal bleeds can be very, very good. And of course, another advantage of doing a PPV in these cases is that some large subretinal bleeds are associated with subhyaloid and preretinal bleeds as well. And doing a PPV is the only way to displace these bleeds. And like I said, 10% is the average number of retinal detachments that happen in patients with massive subretinal bleeds. This is highly unexpected when we consider that we are dealing with a mostly, there's no regma before we go in. So we don't expect regma to just retinal detachment, but this is something that we need to think of when we and be aware of when we go into such cases. So I'll just go through the case. This is a patient, a young patient, had developed a PCV in her 40s, and her vision had dropped to hand movements, almost finger counting eccentric. And you can see she's got a bleed in all layers of the retina. We've got a preretinal bleed, a subretinal bleed, sub-RPE bleed. In such cases, there's really no point in trying a pneumatic displacement because you've got to deal with all the layers. And of course, it's a large bleed extending outside the arcade. So in these cases, we elected to do a pars plana vitrectomy. PVD inductions are always mandatory. In this case, you can actually see where the bleed has broken through to the retinal surface as well. Doing the ILM peel enables us to access the clot, which is sub-ILM as well. So sometimes the clot is very adherent, and we decide not to actually remove that by peeling, just trim it. This is injecting RTPA into the subretinal space. And then, of course, we don't laser, we just do a fluid air exchange and put gas in this case. And this is the visual outcome, OCT. And you can see that the subretinal bleed is very, very small. So in the interest of time, I went through this very quickly, but if there are any questions or discussions that we'd like to have, I would be happy to take them now.
Dr. Jacob, thank you very much for this very nice and excellent presentation with highlighting about topics that we are facing so many times, especially when starting with small subconjunctival submacular hemorrhage, and there is a possibility also to start with anti-VEGF. Then we can go for surgical intervention and it will be a large. I will leave the comment for any one of our experts here, Dr. George, Hassan, and Nabil, please.
Dr. Jacob, excellent talk. It's something that's really challenge when you have a huge amount of money underneath the macula. I think that two things is very important. If you have blood underneath the retina, you need to move this because it's toxic. It's gonna destroy the vision. And if the cloth is not so organized, I mean, less than 10 days, pneumatic displacements work well. But if you have in all layers of the retina blood, like you has shown a beautiful video with limited membrane peeling and everything, it's really necessary. My question, how much TPA you inject subretina in this case? What's your approach for that?
We would like to limit ourselves to 25 micrograms, although even higher doses have been used, but nobody really knows what is a safe dose of RTPA. Also, I think, again, one more thing, like I was stressing on it, really, you need to, if you're planning to, this is a case where we didn't actually remove the clot. But if I've had cases where we've actually had to remove the clot as well. And in those cases, you really have to wait for a long time for the action of the RTPA. But if you're not removing the clot, then I think you can just inject it and leave it under the retina.
Yeah, it's good. 25 micrograms is correct. Those you can go until, if I'm not wrong, until 50. But if you go too much, it's toxic. I have one case a long time ago in my institution. That's the doctor inject more than 50. I think this was the double, more than 100, and we have a lot of RPE change and everything. The visual was like count finger after all, and then have to be careful the amount of TPA you inject subretinal. That's really helps a lot, but if you too much, can be toxic. And thank you so much.
Thank you, sir.
Nabil, please.
Yeah, thank you, Dr. Jacob, for a great presentation.
Thank you.
Actually, what I saw from the OCT you presented from your case, there is disruption of the outer retinal layers. So I'm curious now to know how far after the loss of vision you operated on this patient.
Oh, this patient presented almost 5 to 6 days, and then we operated maybe a day later. So 7 days.
Yeah, so still it got some toxicity in less than 1 week, we can hear, right? And this is very important to counsel our patients about this, right?
Yes, absolutely. The faster we operate, the better the results in such cases, especially in massive subretinal bleeds. And the blood itself is very toxic. While the process itself may be toxic, the blood is very toxic. And if you can operate even earlier, then the results can be better. But in these cases, the patient recovered to approximately 624, I think. But like you said, outer basically the outer segments of the photoreceptors are damaged, the OCT is never going to look the same again, even if you remove most of the blood that is under the retina.
Thank you very much, Dr. Jacob. Any other comment, Dr. Hassan or Dr. Manoj?
I think that the subretinal TB injection and I think that the size of the hemorrhage and the thickness of the hemorrhage is very important because still, according to the studies, this is very important because not just for any hemorrhage you should do that. I think that most of the VRs, practicing this because and even the time after 2 weeks, what the meaning of that doing that for the patient if the clot is there and that already damaged the ISOS or the photoreceptors.
Any other comments from any other colleagues before we move to the next speaker? So we have now our colleagues, Dr. Nabil Rifqa, and he's a veterinary consultant, King Abdulaziz Medical City in Riyadh. My dearest friend, Dr. Nabil, thank you for being with us, and I am honored to introduce you and the floor for you.
Thank you, Dr. Muhammad, for the introduction. My case today will be about a PVR case after a diabetic regular, we can say regular TRD repair. So my patient is a 56 years old diabetic male, unfortunately uncontrolled at all, and you will see from the photos how uncontrolled the diabetes was. So he presented to me with complaining about decrease in vision in the left eye only. So if we see his fundus photos, the vision in the right eye is 20/60, left eye 2100, but there's extensive fibrovascular membranes in both eyes, and we see the florid neovascularization on the fibrous membranes. So immediately I did PRP in one session for both eyes, and after 2 weeks, almost 2 weeks, we can see that we can see the regression of the new vascularization on the fibrous membranes in both eyes, and what is left here, some large vessels at the side of the fibrovascular membranes. So now we can see again, this is before for the left eye, and this is after, less new vessels. But the patient is still complaining of decreased vision in the left eye. The vision is 20/100. He had large VMT and a significant traction on the arcades. So we decided to elect him for pars plana vitrectomy combined with phacosurgery. And this is, I will not go for the TRD repair surgery. We'll go ahead with the next surgeries and follow-up. So this is 3 weeks post our pars plana vitrectomy, and the oil is in place. We can see that we have good PRP scars, good laser around the breaks, and everything looked well. I was happy, the patient was happy. He felt that the vision is better despite being the same on the chart 2100, but he said, okay, the view is clearer for me, maybe because we removed the fibrous membrane which was occluding the macular view. So this is 3 weeks after the pars plana vitrectomy, 3 weeks later. So this is 6 weeks after our primary surgery. The patient came to me complaining, okay, the vision is deteriorating now. The vision on the chart is 2100, 2200. And we have a lot of fibrosis on the retina, mainly on the macular area and on the superior mid periphery. So, but this is very early now, it's 6 weeks. If we go to his OCT, we can see that we have thickening, we have a soda hole, and there is some disorganization of the retinal layers, which was very concerning to me about the visual outcome for this patient. So this patient will need surgical intervention to remove these membranes, especially from the macular area. But when? This is a recent surgery with multiple breaks in the primary surgery, silicone in place. So I postponed, I wanted to pass 2 months after the primary surgery, and almost maybe 10 weeks after the surgery, 9 to 10 weeks after the primary surgery, I went for my silicone oil removal and peeling of the membranes. So this is the video of the silicone oil removal. So I'm examining the inferior retina. Inferior retina was perfect here. And we can see how extensive the fibrous membranes are here. So mainly, again, in the macular area and superior mid-periphery and a little nasally. Starting here with in the inferior temporal macula, I tried many times to get an edge to lift the membranes. I couldn't here. The membranes were very adherent, so I started in another place. Here in the temporal macula, here I was able to lift a little the membrane, so I went inside. It was not coming easily, so I went inside with the cutter to cut this bridge to separate the temporal membranes from the nasal membranes. And continue now with peeling the membranes. You can feel how the membranes are adherent. The retina is elevated with the peeling, and we notice here that the membranes are very adherent at the inferior temporal fibrosis. I couldn't peel anymore here. So lifting again, trying to get a better cleavage, but not anymore. So shifted to another place. So again, peeling, but we can see that the fibrous membrane is very adherent to the vessels, so I cannot peel more. So what to do now? I was thinking here, okay, let's start maybe superior temporal to the macula. Maybe I can get an edge here. Maybe I can peel more membranes since I'm inside, hoping for peeling more. So again, a small piece came, not more. So I inserted here a chandelier to work by manual. We rarely do this in flat membranes. It's tricky here. We are dealing with flat membranes on the vascular arcade. It's very dangerous if we get any damage to the large vessels. Then peeling the membranes from the macular area. We can see the elevation of the nasal macula with the peeling of the membranes. When I reach here, we can notice that we cannot peel anymore, so I trimmed the rest, not to cause any retinal break, which will be a source of more fibrosis. So this is, I'm done with this surgery, air fluid exchange. The patient came to me the first day, he was okay. 2 weeks later, so I was curious to see how the macula will look like after removing these membranes with disorganization of the retina. So the first thing I did, I looked at the OCT. So the macular lamination was perfect, but unfortunately, the retina was detached. This is his Optos photo. We can see extensive fibrous membrane extending from the temporal retina inferiorly and to the nasal retina, with 3 retinal breaks next to the fibrosis here. So I took him the OR the next day. As my habit for PBR cases, I put a band. We hate, all of us hate bands in diabetic patients, but we have to do sometimes. So after that, I stained with membrane blue. So trying again to peel the membranes, we can notice here they are coming in very small pieces, and I couldn't peel a lot too much membranes from temporal macula, so I moved to the mid. Here we have a star fold, so it's mandatory to remove. We cannot leave this, otherwise the retina will never attach. So I'm lifting here the membranes. We can see how large the retinal folds are under this fibrous membrane. So I'm trying to pull, but cautiously, not to cause further retinal breaks here. So trying to extend the peeling. And again, extend the peeling posteriorly, hoping for more peeling of the membranes. But again, we cannot. So I stopped here and I trimmed these membranes. Here I'm trying to peel this fibrous membrane. And we notice I tried many times, but it was not possible to remove these membranes. So I decided to do retinectomy. Retinectomy, all of us know that retinectomy is bad in diabetic cases, but I do not feel that there is another way to flatten this retina other than doing retinectomy. So starting the retinectomy, here there is a funny appearance of pigmented pegs. We can appreciate the pigmented pegs where the PRP scars were. So the common question of our junior colleagues about PRP scar, are they preventive of having RRD? The answer is from this case is apparently no. So despite having good PRP scars, still we have this rhegmatogenous retinal detachment. The pigmentation, this is stalagmites or stalactites, according to how do you see it. These pigmented protrusion from the retina. Here we have some fibrosis under the retina causing adhesion between the retina. We can appreciate here causing adhesion between the retina and the underlying RPE and choroid. So we have to remove all of these fibroses. Now I'm tightening the band and check how it looks from inside to see. And I noticed that the horns of the retinectomy are sitting very beautifully on the indentation of the band. So I decided in this particular case, since I have already a band in place, we can see the anterior flap even flattening beautifully on the indentation. So I decided in this patient to keep the anterior flap. Usually we don't do this. So PFCL as usual to flatten the retina. And starting with the laser to the iatrogenic breaks I made here. Then confluent laser to the retinectomy edges. This is our way in doing laser to the retinectomy or retinal breaks, confluent laser, not PRP fashion. So now with exchange, now I'm drying the anterior flap edges. This is not usual to do. So making sure everything is dry. The anterior flap, we need to flatten the anterior flap here. That's why I'm drying it, not to retract. So doing more laser to the anterior flap. And of course, silicone oil injection. At the end of this case, I was thinking there is already fibrosis, a lot of PVR. So what to do? I can do something. I can inject methotrexate to maybe reduce the likelihood of having PVR, more fibrosis down the road. So at the end of my surgery, I injected intravitreal methotrexate. So the first injection of methotrexate was intra-op, then 1 week, then 2 weeks, another injection. So the third week, I did not inject. The plan was to inject weekly. I want to be aggressive in this patient to prevent the fibrosis. from occurring again, but on the third week, I did not inject according to my plan because of this appearance of the cornea. We know one of the complications of intravitreal methotrexate to have SPKs, and the patient had very severe SPKs here. So always we need to observe the cornea if we are injecting methotrexate. So after 1 week of copious lubrication, the patient came again, and I injected the fourth injection of methotrexate, and I'm planning to inject him bi-weekly till 3 months post-surgery. This is his appearance, maybe 3 to 4 weeks after the surgery. And this is the appearance just the day 1 after the surgery, and we can appreciate that it looks like a smiley face on the retina. So it's funny to see this. This is the first time to do the retinectomy for me in this shape. And at the end, I would like to thank all the audience, wishing you all a big smile on your faces, not on your retina. So, and thank you again, Dr. Muhammad Amri. Thank you, Dr. Muhammad Abdullah, for the invitation.
Thank you very much, Dr. Nabil. Great surgery. I don't know how you insist to go all through this one. I will not be patient to go all this, but anyway, if there is any comment from any one of you, Dr. Hassan or Dr. Jacob, we have 1 minute. Then we can move to last talk, Dr. Hassan.
I want to thank Dr. Nabil. Excellent case as expected, and the surgery. And I think is that could be that there is any, you will keep inject the patient. If the patient develop any BBR, you will keep inject patient, because still there is debate around the injection, the rule of the methotrexate around more overall the world, despite of the GAD trials. If you find there is any fibrosis, increment in the fibrosis in the patient under silicone oil, you will keep inject the patient, or you will stop and remove the oil, remove the membranes if there is any traction. And when you want to stop, when you want to stop, because sometimes they say 13 injection, 6 injection, what's your decision for the patients?
Okay, thank you, Dr. Hassan. It's a tough question. So if we have fibrosis, more fibrosis, should we stop the injection or go ahead with more injection? I personally, I would go ahead with more injections, because I would feel that the patient will develop more fibrosis if not injected. But it's maybe it's controversial. Some would stop, some would go ahead with more injection. But for myself, I would go for more injections.
Okay, is there any other comment, Dr. Jacob? Okay.
Thank you for such a wonderful presentation and lovely videos. This is one of the reasons why I've actually started doing a foveal sparing iron peel in all diabetic TRDs now. I never used to do it initially, but now I do it in all my cases because of the amount of fibrosis that does develop in these cases. I don't know what your take is on this, but I personally have seen quite a lot of improvement. Initially, I never used to do a fovea sparing ILM peel. I should peel it off the fovea, and I noticed that there were some macular holes happening, which is why now I've shifted to doing a fovea sparing ILM peel in all diabetic TRDs. And I find that it has improved the foveal contour, although there may be some cases which have some amount of foveal thinning, but on the whole, it seems to improve the number of patients, reduce the number of patients developing fibrosis. What is your take on doing a primary ILM peel on the first surgery itself in such patients?
Yeah, thank you, Dr. Jacob. Great comment. Great comment. Actually, so how I approach these cases, if these cases are simple, so I try to avoid peel the ILM. But once they are more complicated, and if I see some striae on the macular surface, I tend to peel the ILM. But sometimes your judgment failed you about the case, like in that case. So yeah, but yeah, good comment. And so most of the time in complicated cases, I peel. I refrain from peel in simple cases. So to avoid, maybe I feel that shape of the macula would be better if you don't peel the ILM, and maybe the visual acuity would be better. That's why I don't peel for all of my cases.
Thank you very much, Dr. Nabil. Thank you all. We can go to our last presenter, Dr. Hassan. He will do it in a very fast, as he tell me, inshallah. So we will finish very soon.
Just I want to present the case of Dr. Muhammad. Dr. Muhammad, you can see my slides, yeah?
Yes, we can see, please.
Um, this is case with 8 years lady and with family history of retinal detachment of the father. The patient came with light perception. You can see that there's giant tear around 270 with inverted posterior flap, and the patient has retinal tear in the other hand. Suspected according to the midfacial manifestation, the patient has stickler like minus 16 or 17. So we took the patient for the OR, and you can see the surgery here. We removed the membranous vitreous. According to me, this is it was a stickler wasn't there. I remove all the anterior flap of the giant tear. I don't leave it. And here is the trick to open the sandwich and put as before put any BFCL to clean um, the vitreous phase, which will have the recurrence, as we mentioned in Dr. Nabil cases. Yeah, I am very, very aggressive in that to use the nano brush. In spite of you here, the epithelium was hazy, become hazy. So after that, I remove it. So I try to clean all the expected vitreous, as here the vitreous face will be adhered to the retina. So in spite of, I try to remove it, and you can see some kind of. Then I use in spite of, I colored by Vision first, but didn't take the staining. Then I inject the VGL under the BFCL. You can see here multiple times until just to remove the remnant. And I use, generally I don't use the contact. I use the contact and I remove here the vitreous. And I remove the ILM around the macula, as Dr. Jacob mentioned, because I don't need anything to traction the posterior pool, as I am dealing with the periphery of the retina, as there is no vitreous space factor to traction the retina. The patient has around 360 tear. So after I remove this, and the patient, and the myopic generally, I suffer in the visualization when I use the biome system. Here you can see the macula after putting the BFCL. It's atrophic macula. I try to remove the vitreous face, and I use the, say, Teno brush first, and the far periphery here around it. Then I use the vitreous, the forceps is to remove the vitreous face from around the tears. And as you remove the vitreous face in the first surgery, you will not do second surgery for the patient. So you should be keen in this situation, despite of sometimes in the far periphery will be both of the surgeon, then he will postpone, and then he will suffer during the second surgery. So I feel that as I have multiple cases from this giant tear in the children's, so remove it. Then I remove the air and fluid exchange, and I put oil for the patient, and inject oil for the case. And after 3 months, I remove the cataract and the oil, and can see the retina is attached. And I will just want you to see the case. I augmented the posterior bore, and you can see the case here after this is the case after the oil injection, and this is the case after removing the oil, and the vision is 0.4 and stable. So as I know that Dr. Nabil will present the methotrexate case, I said let me bring in a case, then it will be debate. So I don't know what your opinion about the giant tear, and
Thank you, Dr. Hassan. Really, today we are having a great cases. So in a fast, we need a comment, but I will ask Dr. Hassan, Dr. Nabil, Dr. Jacob, if you can do the evaluation and send me in my WhatsApp, please, personal WhatsApp. Meanwhile, we will hear to all of you who commented on Dr. Hassan case. Any question or comment? Nabil or Dr.
Yeah, Dr. Hassan, a great case and mashallah, a great outcome. So all of us agree with you about the peeling of this cortical vitreous, this thin vitreous cases layer. And yeah, as soon as you remove more, as long as you remove more, so you expect less fibrosis. But at the same time, is it 100% prophylactic from getting fibrosis, from getting PVR later on? What do you think? I think the chance of getting PVR is still there, even if you remove any tiny vitreous island from the retina.
يعني, as you mentioned that there is no one guarantee, but according to the discussion, Dr. Nabil, they said in the retinal detachment of theirs, you suspected the BVR would be there. And as Dr. Jacob, he mentioned, the ILMs for me is the scaffold to which will be affect the central part of the retina. So I try to make it, to avoid it from my in these cases, to remove the ILM or fovea sparing. I prefer it. If there is, in this case, it was the remnant of the vitreous and the macula, so I decide to remove it from the macula. So I think that to manage to remove the ILM, it could be give the option that you remove all the membrane of the retina, so reduce the BVR or make the BVR just in the far periphery. For that, I feel that it could be that يعني staining and remove these kind of membrane. If you suspect it, then you go for the ILM. It will reduce the BVR. This is my through my cases, maybe the number of the cases which I did it not so much, but I feel that when you remove the membrane, even if you have BVR in the periphery, you can manage it by a buckle. It will not affect the central of the vision, the macula. It will not reach the macula unless you have a break.
I'd like to add a point there. Actually, I completely. It's a beautiful video, Dr. Hassan, and also I completely agree with you. For PVR to cause a retinal detachment, a secondary regmaticus retinal detachment, where there is a new tear occurring post-operatively. I always find that there are two membranes, one in the periphery and one at the posterior pole. And if we can peel the ILM, we will not have a membrane at the posterior pole. In pediatric RDs, GRTs, we are almost certain when we remove the oil, you'll always find an ERM if you've not done the ILM peel in all these cases. So if we remove the ILM, a broad ILM peel in such cases, we remove the possibility of the posterior membrane forming. And if there is no posterior membrane forming, even if an anterior membrane forms, the detachment is very manageable and shallow. If there is a posterior membrane and an anterior membrane, then there is often a new tear developing in between the two, and the management of which becomes much more challenging. So this is why I always, in patients with high risk of PVR, even if they don't have an obvious ERM at the posterior pole, especially in pediatric RDs and GRTs, I always, and traumatic RDs also with vitreous hemorrhage, I tend to do an ILM peel, and I really think that it makes it much more manageable. Thank you for raising such a valid point as well.
Thank you very much for all of you. Really appreciate all the presenters, either our expert or young ophthalmologist. It was a great meeting with a lot of information and discussion and debate. And I'm waiting also for Dr. Hassan, Jacob, and Nabil. If you can share with me your evaluation so we can announce. I would like just to announce the last week competition between young ophthalmologists. Anyway, I want just to mention that all of them have done a great young ophthalmologist either this week or last week, and the numbers are almost very close. There is only 1 point is different. And the last week was the winner of the competition was Mohammed Sarhat from Turkey. The other colleagues also, they are winners, and the company management event will contact them and send them what they are going to get in the 7th MIOM conference. Waiting for the result of today. So I'm still waiting for them. Dr. George have done, I don't do anyway. I'm just mentioning the result. So if you want to blame anyone, you can blame only the other expertise, not me. Um, for this week, Dr. George have done, and also he is mentioning all of them. They are in a very close. So just waiting for others. I think Nabil, he will share with me now, and Hassan, Jacob. Then we will see what is the result.
I've sent you a message already, right?
No, you send me second. 1 second. Okay, I get you. Jacob, are you going to send me? I'm waiting only for you. Okay. So for today, the winner is Manoj. Congratulations, Manoj. Also, I want to tell that the others they are also uh, there is no one loser with us. Just we are just mentioning like this, but the company or management event they will send you an email. So and will mention with you. The only difference I think the first one he will have the chance also to participate as a speakers. The other they will be equally have the same result, and also they will get whatever they will announce, and they will tell them in the email. They will send them an email. I would like also to announce for all and others for the next in April that we will have around 2 sessions of webinar, so everyone able to apply, and we hope to see you all. Thank you very much, Dr. Nabil, Dr. Jacob, Dr. Hassan, Dr. George, Dr. Boris, and also Dr. Muhammad. Can you tell me your name exactly how we can pronounce?
Burjo.
Burju, okay.
Burjo.
So,
Thank you very much.
so thank you, Dr. Burju. Thank you, Dr. Muhammad and Dr. Manoj. And thanks for the management event. Thanks for Bayer for sponsoring this meeting. And we hope to see you, inshallah, very soon after Ramadan. And happy Ramadan for all of you, dear colleagues all over the world and all dear brothers.
Thank you,
Okay.
Dr.
Thank you very
Thank
much.
you, Dr. Hamad.
Thank you.
Thank you.
Thank
Bye-bye.
you. Thank you. Thank you, everyone.